Let's walk through anxiety disorders in a way that actually sticks, when you're just listening and trying to picture these patients in your head. So imagine you're in clinic and every patient is saying, "I feel anxious." Your job on step 3 is not to just label anxiety, it's to figure out what kind of anxiety. And the easiest way to do that is to ask yourself 3 questions. Is it tied to something specific? Does it come out of nowhere? Or is it always there? That's your framework. Let's start with phobias. Think of phobias as a very targeted fear. These patients are completely fine until they encounter one specific trigger. So picture someone who is calm, normal, functional, and then suddenly sees a spider and completely loses it. That's a specific phobia. The key feature here is that the anxiety is immediate, predictable, and tied to a specific object or situation. Boards love to describe this as anxiety immediately upon exposure. And here's a high-yield rule. Symptoms must last at least 6 months. Now, treatment is where they try to trick you. For specific phobias, the best treatment is not medication. It is exposure therapy. Gradual desensitization. So if you see fear of flying or fear of heights, do not jump to an SSRI. The correct answer is exposure. Now let's shift to social anxiety disorder. This is not about spiders or heights. This is about people. These patients are terrified of being judged, embarrassed, or humiliated. So picture someone who avoids public speaking, presentations, even eating in front of others. That's your classic clue. And this usually starts in adolescence. Treatment here is CBT and an SSRI. But there's a very classic step 3 scenario, performance anxiety. The patient says, "I get shaky and my heart races before presentations." That's when you give a beta blocker like Propranolol, not a benzo, not an SSRI. That's a very targeted question. Now let's move to panic disorder. This is completely different. There's no trigger. This is anxiety that comes out of nowhere. Imagine a patient sitting on the couch, doing nothing, and suddenly feels like they are dying. Heart racing, chest tightness, shortness of breath. That's a panic attack. And the key feature is it peaks within 10 minutes. That's a classic board clue. Now use the panic's mnemonic to picture it. Palpitations, abdominal distress, numbness or nausea, intense fear of dying, chest pain or choking, sweating, shaking, shortness of breath. It's a full body event. Now here's the diagnosis piece. You need recurrent, unexpected panic attacks, plus at least 1 month of worry about future attacks, or behavior changes to avoid them. So if the question says, patient stops going outside because they're afraid of having another attack, that's panic disorder, and often this leads to agoraphobia. Fear of being in places where escape is difficult, so they avoid crowds, public places, even leaving home. Now treatment. First line is an SSRI and CBT. But here's the step 3 nuance. An SSRI takes time. So for immediate relief, you can use Benzodiazepines as a bridge, short-term only, because of dependence risk. So if the question asks for immediate symptom relief, a benzo is reasonable. But if it asks for long-term management, an SSRI is the answer. Now, very important, always rule out medical causes. If someone presents with panic symptoms, you have to think, could this be an MI? Hyperthyroidism? Hypoglycemia? If the STEM gives you any red flags, you investigate before diagnosing panic disorder. Now let's move to generalized anxiety disorder, or GAD. This is very different from panic. There are no sudden attacks. This is constant. Picture someone whose brain just never turns off. They worry about work, finances, health, family, all day, every day, and they can't control it. The key diagnostic rule, anxiety for at least 6 months, plus at least 3 of the following: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, sleep disturbance. And here's a classic step 3 clue. These patients often come in with physical complaints, headaches, fatigue, or stomach issues, because anxiety shows up in the body. Treatment for GAD, first line, an SSRI or SNRI. Also, boost bar and CBT. And again, benzos can be used short-term as a bridge, but not long-term. Now let's tie this all together, because this is where you really start getting questions right. If anxiety is tied to a specific trigger, think phobia. If anxiety comes suddenly, out of nowhere, and peaks quickly, think panic disorder. If anxiety is constant, generalized, and lasts for months, think GAD. And here are the traps. If you see chest pain and palpitations, don't jump to panic. Always rule out medical causes first. If you see a specific phobia, don't give meds. Use exposure therapy. And if a patient wants quick relief, benzos are okay short-term, but not the long-term answer. So here's your rapid mental summary. Specific trigger, think phobia. Sudden attacks, think panic disorder. Constant worry, Think GAD. And an SSRI is your long-term foundation. CBT is always helpful. Benzos are short-term only. And always, always ask, is this psychiatric? Or could this be medical? That's how you stay one step ahead on step 3. Thanks for listening. If this review helped simplify a difficult topic, consider subscribing for more high-yield medical education content. And let me know in the comments what topic you'd like covered next. Until next time, keep learning, keep growing, and keep expanding your horizons.